Hi everyone. Welcome you all to our webinar on DHIS and how to maximize, uh, your earning with NHS Digital Health Incentive Scheme, basically. Thank you all the doctors who have joined us for the webinar and our panelists, especially Mr. Narendra Singh and Vikalp. Thank you so much for taking out your time. We'll start with our first session without any further delay. So our first session will focus on an overview of DHIS and how Eka Care is facilitating doctors to join this ecosystem. Very happy to invite Vikalp for this session. Just small brief around him. He's the founder and CEO at Eka Care. And Vikalp has built Arogya Setu as a volunteer architect for the government of India and was the co-founder and CTO at GoIBibo. With nearly 18 years of experience and breaking ground in the travel industry, he is now considered one of the leading voices in health tech in India. So, Vikalp, over to you. And yeah, thanks. You're on mute, Vikalp.
Oh, sorry. Thank you, Dr. Sanjana, for the kind introduction. And thanks to all the doctors, participants. I think it's always been my pleasure to speak to so many doctors. I mean, you guys make us happen at Eka Care. Thanks for the whole team. And most importantly, thanks to Narendra ji. Thank you so much, sir, for being part of this webinar. Having NHA coming over and speaking to our doctors and giving shoulder to us in this journey is something that is making us grow. Thank you so very much. Without more ado, I'll just start by a little brief about us. As Dr. Sanjana mentioned, from travel to health, it was a very interesting journey that was pivoted thanks to Arogya Setu, but eventually ABDM gave like a big ground for us to begin and scale, and hence since last 3 years, we launched in June 2021. We have tremendous growth in our PHR and EMR apps. We have two products. One is EMR that all of you can try out, use as a doctor partners. On the other side, for your patients, we have our patient healthcare app, which is for your medical record and needs related to health data management at a patient level. Quickly, how we see this entire ecosystem building and growing up. For us, what NHA government is doing with ABDM is practically what we see as a UPI moment in healthcare. The way UPI has made transactions possible at all various aspects of the society in India. Similarly, we believe that NHA with ABDM at the heart of it, core of it, will do it for health. We see it very simple, as has been explained by us to NHA. There will be interoperable healthcare service providers such as hospitals, labs, doctors, which would work with a certified software provider such as Eka Care or many other certified software provider to connect with a ABDM gateway hosted by the National Health Authority. Narendra sir is part of that team. And then it connects with stateless APIs to all kinds of PHR apps, which is very similar to what PhonePe and Google Pay act as, fundamentally from a patient or a user's perspective, where they can reach out to the doctor, they can connect to a hospital, they can receive the documents, do scan and share, and many other activities from a patient side. If we look at it, how this is changing the landscape, this is changing the landscape in two key areas where suddenly the landscape will look very different. And as an EMR provider, what excites us also a lot, when we work with doctors such as yourself and hospitals and clinics, we realize that every single doctor, every clinic, every healthcare provider, be it labs, they all create something called a UHID. But this UHID practically is a UHID that is focused on an individual clinic. So Manipal Hospital will have a specific UHID. Apollo Hospital have a specific UHID for the same user. Now, what government is trying to say is, what if I create a global UHID, which is ABHA, and that ABHA is linked to the UHIDs that are being created across all of these various individual healthcare providers. I think that is super exciting because when I look at it from a digitization perspective, doctors, clinics, hospitals, healthcare providers create UHID so that they can see the patient's history, because in healthcare that is very important. Now, if this gets filled by the history that is collected at many other healthcare provider, which is what ABHA would do by creating this global UHID, I think this will solve a lot for the outcomes, and also the digitization will be possible. So we as a company are super excited about it, and also our EMR is fully capable, and ABHA creation is a first class citizen on Eka Care EMR. It is very easy. Don't want to boast about it, but easiest maybe in the in comparison to the way we have seen in the market. The other thing is we do a lot of work with our doctors to run campaigns, to run workflows, so that the patients who are older patients of a doctor are also being subscribed and the ABHA ID is created. Now, this is the fundamental first step towards also reaching that goal that we are talking about today, is of getting eligible for incentive. So once the ABHA gets created, the important thing that ABDM is looking for is this ABHA or this health ID should have document associated with it as well. Now, if this UHID is once created, the medical data will start getting feeded into this ABHA ID or the global UHID that government is maintaining. Eka EMR, again, very seamlessly during the workflow practice of a doctor, as soon as an ABHA gets created, which is again a very simple process, like the way you register your patient, name, number, and then there will be OTP triggered by the government, by their system to generate the ABHA ID. Once that is done, a doctor has to simply create that medical record, which is the prescription that a doctor is creating. With this medical record, if there is an additional information of vitals, or if there is an additional information of certain other values that you want to capture for a particular patient, all of that will become a bundle of a medical data, which will get linked to that ABHA ID that has been created at the clinic. Now, that fundamentally just solves for most of the requirement that we needed to get this transaction eligible for the incentive. As we are seeing this global UHID or the ABHA ID will get more and more penetration, the more and more medical data will get generated by using the digital tools such as Eka Care, and government, for making sure that this gets pushed larger, and more importantly, because this might entail certain costs. For example, an ABHA ID creation might entail a cost or a pressure on the staff. A digital prescription creation might take or entail a cost on buying a subscription package of an EMR software, or so and so forth. Government is giving incentives so that this entire program can be pushed forward. How this incentive works today is there are various categories, be it a hospital or a diagnostic facilities, labs, or a digital solution company. They are all will be part of this incentive scheme. The DHIS says that if you create an ABHA and link a record, which is very important to understand, linking of record can only happen if there is an ABHA created. So creation of ABHA is where the patient has to give a consent that, yes, I want to create an ABHA by giving that OTP. and then a valid medical record needs to be generated. Once that valid medical record is generated, they all will become part of that linked document, or in the tech architecture terms of NHA, it is called care context. Once that care context is created, we link that care context through Eka EMR, and that would make doctors and the facilities eligible for this 20 rupees incentive. Now, there are certain riders to it. These riders are such as the number of times a facility can link a document for an Aadhaar ID, which is 5 times in a month. Also, daily, it could be only once for an Aadhaar ID. And these are all to make sure that there is a right utilization of the scheme. There has been many facilities. They are already doing this with Eka, and we've been able to successfully deliver. We are the largest HMIS or a EMR solution on ABDM to link records on a private side. Obviously, there are many other government EMRs such as eShushrut, eHospital, etc. They do a lot of linking of record and creation of Aadhaar. There is a very transparent dashboard. I think this link, we'll share it with everyone. Maybe Dr. Sanjana, you can share this link on chat as well. It's a dashboard that actually provides real-time information about what is happening. If you go there, it might take a little bit of time, but you would know the number of doctors linking the record, number of healthcare providers linking the record, and so on and so forth. Let me just, I think this, can you see my screen, Dr. Sanjana? Or it's just
Yeah,
blank?
but it's loading. It's just blank right now.
It's just blank right now. Yeah, maybe because it's loading. I'm
Loading.
going back to the deck.
I'll post the link on.
Yeah, you post the link so that doctors can look at it by themselves. There are many data points there. Every facility can look at their contribution towards this mission that ABDM is carrying forward transparently, which is again brilliant from NHAs and government side, where it's very transparent how this is happening across the board. Again, we are obviously an EMR. ABDM is one core mission, but there are multiple other things also that we provide, such as Google management, writing of prescription, SEO boost, billing support, and so on and so forth. So all of that is again part of the package that we offer at Eka. It's not necessarily only the Aadhaar creation as well as the linking of the record. It's a inherent part of the complete package that Eka has, right from the digital solution of your presence to the end solution of writing prescriptions and managing your clinic end to end. With that, thank you so much for listening to me. I hope this was I mean, this answers some of your questions, but happy to answer any more questions as the webinar proceeds. Thank you so much.
Thank you, Vikalp. I think there were 2 raised hands. We can probably take 1 or 2 questions before we move to the next session. Dr. Saurabh Rai, sir, I think you had some questions. Hello, sir. You can unmute yourself if you're speaking. Okay, let's try Dr. Deepak Jadhav. So you can ask your query right now. I think you'll have to.
Am I audible, ma'am?
Yes, sir. Yes, we can hear you. Hi, Dr. Deepak.
Hi. How to convince patient to give OTPs to register in Aadhaar? Or what if he refuses to give OTP?
No, sir.
How to tell him that it is for your benefit?
Yes, sir. No, it's very valid ask. And I think some of the things that worked for us is if there are any collaterals or anything that you can print out on the clinic, which is about NHA and about ABDM and about ABHA, because that will give a trust marker to the patient that this is a government initiative. I think there are many collaterals that NHA has on their website that can talk about it. It's an important point, and we are also thinking of working with NHA, and Narendra sir can add more to it, so that there can be a standee or a poster that can be fixed on the clinic, and that can actually add more trust to the and more convincing to the patient, because this is like a government initiative, and when you talk to the patients that this is by the government, it instills that trust.
Okay, thank you, sir.
Thank you, sir. Thank you, Vikalp, I think, for trying to simplify and explain to our doctor community around ABDM. I think we'll move to the next session. We very pleased to have Mr. Narendra Singh, sir, with us. He has over 22 years of experience in areas of information technology and e-governance. He's worked with various government departments across central, state, and local bodies. He currently works as a governance consultant, focusing on reforms in the public sector, restructuring policy changes, and automation of processes. So, thank you so much for joining us. Eager to hear from you how ABDM is transforming healthcare, leveraging technology.
Thank you, Dr. Sanjana, and thanks, Vikal. Actually, I should not be saying thank you, because whatever I was about to say about ABDM, you already covered most of it in your presentation. But I think I'll try to, Vikal gave a very good overview of what ABDM is and what, I think more of it is on the technical side, he was talking about DHIS. But what we, in simple terms, what we are trying to do here is that a patient, if a patient is going to various doctors during their lifetime, instead of keeping all their records in a file or somewhere, if it is a chronic disease or any other thing, they get access to all those records on their mobile. So some time back there was an ad, Karlo Duniya Matti Mein, when you had a mobile. So now we have all your digital records on your mobile. So when you create a ABHA ID, the patient will get every record, whether they can go to a doctor, the doctor will write an OPD prescription if is a, and then when they go to a lab and they do their test done, they will get all that in a single app. It's not like during the COVID times, we all got our test done. Not all, some of our, then we used to get an SMS, and you download that report and you keep it somewhere, or you'll get it somewhere on a Gmail. After some time, if it is required, any such record, not the COVID, but any other record is required, you need to search for it. Even if it is an electronic record, you need to search for it. मैंने laptop में कहाँ रखा था, or where I kept it on my hard disk, or if it is a physical record, you need to search for that file. So this thing is taking away that whole idea of keeping track of. And the good thing, it's similar to what you have. You have all those financial apps right now. They are account aggregator. You want to see where, or what are the amount, if you have multiple accounts, you can check balances on a single app, and you can also see your transactions. So this is the kind of thing we are trying to achieve through ABDM. And in this case, there are two things which are required. One is that hospital management systems or any clinical management system which are used by doctors to create those records. It's not required. When you say a record, it's basically what you're writing on paper, an OPD prescription. You are writing that on a computer system, and it is saved there. So in a banking system, we have core banking system which are used by all the banks. And unfortunately, in the hospital and digital doctor world, we don't have only one or two 5, 10 big systems which are taking care. We have small systems which are used by many doctors. And what we have done under ABDM, we are not saying that you all migrate to one big system or 5, 6 big systems. You can look at various clinical systems which are developed by various organizations which suit your need. and where you're just creating a digital record, and it's just as we transfer money from ICICI Bank to SBI to IDFC, any other bank, we don't bother which systems they are on. Similar kind of thing will happen is happening in ABDM. If a doctor is writing a prescription, or lab is creating a report, or any other diagnostic system, or anywhere a record is getting generated. If I go to a pharmacy, they will create the invoice bill. That is also a part of a pseudo health record system right now under ABDM. So, and all this can be is visible across system. And one more thing, I think there is a misconception. We are not creating a centralized warehouse of all these records. I think when we say a common UHID, ABHA is a common UHID for a patient. It is linking is happening in under various systems. So in Eka, under Eka, if you just enter ABHA for a patient once, you don't need to enter it again. And you don't need to refer to whether it's ABHA itself. You can continue referring with your own system, or you identify a patient with a mobile number. That person can still be identified the way you are identifying. When a doctor, you can search with the name. But only thing is you need to link that person with that ABHA once. And whenever doctor is writing a prescription as yourself, it will be saved in your system. It will stay there. If the patient goes back home and they want to keep a copy, they can pull that record. It is visible only on their mobile application. It doesn't come anywhere. It doesn't go anywhere. If the patient is going to some other doctor or some other hospital, suppose in some other city, and they want to see what happened, 1 year back, then that doctor may be able to request, and on the patient, this is record will go. So I think one thing which I like to clear here, there is no central warehouse of any records anywhere. It's a centralized ID system which is there in your system. So I won't even know whether ABHA is there unless and until you tell and you save the record. So that is one thing. And one other thing, I think as doctor, if you're using a digital system, you don't need to, after you have created an ABHA and linked into the system, you don't need to do anything else. In future, you just need to write a digital prescription. It is a system which is done in back, and you're not doing anything different again. You are treating your patients the way you are treating them. If the history is available, if they're continuing with you for a long time, the history is available with you on Eka system. I think Vikalp is taking care of that already in the system. That, or if they is gone to any other system, you'll get access to that history. So ABDM is only is adding the kind of information that is required for you. It is not creating an additional burden on any of the doctors to create a digital record. If you are using a digital system, you can continue using it the same way. Only it's the first time when you create the ABHA. I can tell you from we have one lab systems which is HLS. So they migrated to the new version of ABHA creation. It's not working. So I think that's not the issue either. But people whose records are already linked into the system, if they go to them and the reports are generated, that is already getting linked. So they're getting those numbers right now, but they are not able to create ABHA. So you're not doing anything, extra. And what we are doing here, I think Vikalp already talked about our DHIS scheme, where we are we are giving an incentive to all the doctors who are trying to use this system. But apart from that, we are also creating this thing that all other doctors who are not onto the digital system, they also come on board. So see, unless and until I think at one point of time, digital transactions you used to do. If you go to a place, you talk about Paytm say paisa dena, so that guy would not take. Sometimes he'll take, sometimes, but after that, phone pay, digital, it became all pervasive. Now it is easier for anyone to pay electronically because it is used everywhere else, and people are comfortable with. So we are also creating a system where other doctors come to know about it. They come to know about digital systems. So we have launched a 100 microsite project. So in 100 places in this country, people are going and people are contacting doctors and giving them information about using digital systems and using information about ABHA. So as someone had asked whether people, patients are reluctant to give their OTP, but you're not reluctant to give your OTP if you go to, somewhere in a banking system, you give that OTP to that person. So because we are trying to see that everyone comes to know about it. So we already have covered around 63 crore people already have ABA. We have a long way to go around. I mean, the population of this country is 140 crores, but if you look at the adult population, it will be less than that. So we already covered around 60 to 70% of the adult population of this country. So that is one project we are doing, creating awareness about digital health usage by doctors, and we are also doing various campaigns about ABA. Some of it was low-key during the last 3 months because of the election phase, but now we are again create. So your patients would be knowing about ABA uh, and the associated benefits with it. And there are various PHR apps where you can access your records, and Eka Care is one of them. So I'll not name the others, just because this is a Eka Care forum. But anyway, we also have our own government app, which is ABHA, which is like a Bheem. Uh, so as you said, government apps are not, we don't give too many facilities. Basic things are available there. You can uh, create your ABA, you can see your linked records, but all other apps can give you trends and do analytics for you. That is available. Other program which I think, going forward, which you will find very useful, uses of ABA will be the National Health Claims Exchange, which is coming up, uh, which will be there. We are, some of us, on the forum, I don't know how many of you may be running hospitals, or you may be running, your own clinics. So claims, OPD claims are currently not there in this country most of the time. But even if you have cashless IPD claims, uh, if you go to a hospital, it will take you, if you get admitted in the morning, it will take you 4 or 5 hours. By the evening, you come to know whether your claim, you are covered under insurance or not. They will ask you all sorts of documents in between. And if you're lucky and you get out of the hospital 2 3 days later, the doctor will come in the morning at 8 o'clock. The doctor will tell you you are all fit to go home and everything. And I don't know if you're lucky enough. I mean, I have been told by the doctors at 8 o'clock, 9 o'clock in the morning, and I left the hospital only around 4 o'clock in the evening. And once it was 8 o'clock in the morning, when the sun is coming up, and when we left the hospital with my wife, the sun had already gone down. It was dark. So that's the amount of time which takes, which is there in a normal insurance process. And in between, as a patient, it's not the waiting time. Sometimes they'll ask you this many records. So National Health Claims Exchange will reduce all that. It will be protocol-driven system. We have already tested it with a lot of insurance companies. I think 30 insurance companies have already signed on board with them, and we have done POC. So it will go live in such time. And I think once all this happens, even percolation of insurance to other things like OPD may become a norm, because I think electronic some of the things, it's a electronic record, it's verified with kind of data. That is something which I think prevents a lot of insurance companies from offering that. They don't want to rely on paper based records. So that's where digital health and ABA, and ABA is the thing which is driving that insurance. So anyone who would like to have go through NHCX would need to have an ABA. And other thing which we already, when there is a Vikalp was talking about UPI moment, we will also have a UHI moment soon, where you may be interacting with various apps and talking. If you want to do a teleconsultation sometime back, or you want to book a test, you would need to go through specific apps, and have only those specific, you can access only those specific doctors or labs on that. Or then if you don't find your thing on the other thing, then you go to some other app. But now with paid, I mean, in UPI, you don't money to anyone. You use the, that QR code of the person, other whether he's on Google Pay, Paytm, or any other app. So money gets transferred back. I mean, even if so similar kind of thing is happening in UHI. Teleconsultation is live with some other things, but we are looking at booking of test and many other things. So I think the digital revolution, what will happen is it's that cusp is already there. I think with the new government coming into play and everything is there, we are all looking at things that now will drive everything. See, in NHA, we are already running the largest insurance scheme, not a AVDM, PMJY. It's a digital insurance scheme. So if you're looking at the people who are below poverty line and everything, their whole insurance is managed by government through a digital platform. And similar kind of thing we are now offering to the whole private sector. It's not only digital insurance platform, but everything. So we have tested everything as government. That electronic things work in this country. The platform is there, the network is there. I don't think you can go to any corner of the country and say my mobile is not working, my data is not working. It may happen for some time, but I think I mean during the day maybe 1 hour will be their worst case, but most of the time it is working. So those three things, I think HCX, UPI, and the microsite projects, we are not limiting ourselves to 100 projects. It will go more than 100 projects, 100 sites. So I think that's from my side, what we're trying to do. But I think you may have multiple questions. I'm there to answer for those.
Thank you, sir. I think it gave a good view on what the general overall vision of ABDM is, especially solving for insurance as well and the entire healthcare ecosystem. There have been some questions. I think the Dr. Vishal Shah has some questions around the data storage. Sir.
Yes. So I have a doubt if private healthcare facilities start using this and they have their softwares integrated with and have this ABHA IDs created for all the patients which don't have already, and all the reports made by prescription or a lab report. So is this data going to get pushed to any central server via which the patient can access remotely later down the time?
No, sir, I think that is something which we are doing. We are not keeping any record anywhere. So what happens, let me just say, we have a health information exchange and consent manager. What we do is if I go to a doc, let's say I went to a doctor in January, and the doctor created a digital record that, and they have, so an entry is made in our system that, okay, Narendra Singh went to a doctor A on this date. And some
Okay.
record exists for this person on the doctor system. I go to another doctor, so similar kind of entry is made for me. I go to AIMS Delhi, an entry is made that Narendra Singh went to AIMS Delhi on 16th of June, and a record is existing from him in the system. So that's what we have, because but there is no centralized system which has what the doctor wrote in the prescription, what was test was there. But suppose so. When I want to fetch it on my mobile, a request is sent to both the doctor system, the doctor whom I visited in January, and also to the AIM system, and that record is coming onto my mobile app. AVDM as a system even doesn't do anything about it. It's acting as the post office. So the record from the doctor system to. So we're not keeping any central. We will not be a central warehouse for any of these things.
Okay, so I assume this is the government is just keeping a logs of the visit, the time, the number of visits, and the time at which the visits happen. And in case of any access of data has to be there, the server at the healthcare facility level has to be live. Then only it can be fetched by the patient remotely down the line.
Yes.
Okay. Thank you.
Hello, sir.
Thank you, sir.
Hello.
Hello.
Am I audible?
Yes, sir. Yes, Dr. Deepak.
I want to ask that do these records are accessed by insurance companies, and what about the privacy of patient if then?
Yeah, so as I said, record sharing, record access by any other person apart from the patient is only by the consent of the patient. So what happens? Suppose let's say not about the insurance company. If I go to a doctor B, so currently what happens? The doctor asks you your medical reports for last 6 months, then you show it to the doctor if you have a file. In this scenario, what will happen? A doctor will request for Narendra Singh, send me your last 6 months record. So whatever from the directory, a message will come on my phone that doctor, let's say Dr. Deepak Jadhav is only asking for his last 6 months records, and these are your 6 records. Do you want to share it with him? So in that case, also I can also decide. Let's say the 5 records, and I just want to share only 4 of them. Maybe one record was just I had gone to a doctor, it was just minor fever. I don't want you to waste your time going to that record. So I say these 4 records, Dr. Jadhav can have access, and those records are pushed into a system, and you see. Similar kind of thing will happen with insurance agency. If you want to do a claim with an insurance agency, they will want to see your previous records or the current record. So those records will be shared by consent. If you want to buy a policy, and as a part of the policy, they want to see your medical history for last 3 years. So a request will come to you. See, these are your last 3-year records. Do you want to share it with the insurance agency? You want to share or you don't want to share? That is up to you. If you don't share and something uh, because of hiding of data, something happens, that's a different. But no one has access to your records unless and until the patient says, this record I want to share with the third party. So as I mean, you would all have heard about the DPDP Act, which just came in recently. I mean, the act was, it's not yet notified, but it was passed by the parliament. So there also, all the parameters which are there, and the ABDM data management policy, we are all through on that. So we are meeting all the requirements of the DPDP Act.
Thank you, sir.
Were there any more questions? I think in the chat, sir, there was one question. Maybe Narendra sir can also like reinstate and comment. They're asking if it's necessary to always complete 100 records to enable the incentive, and which are the specialities of doctors for which DHIS is eligible, for which they'll be eligible for.
Yeah. So DHIS, I mean, everyone is eligible. Whoever is a doctor.
Irrespective of Ayush or dental.
Yeah, there's no speciality. It's even I think we have a health professional registry on our site, which we're maintaining for our doctors and nurses. Doctors across all branches can register there. They have to be approved by the council. For DHIS, we are not limiting only to doctors. Labs are also a part of the whole scheme. So if you're running a lab, pathology lab, they're also here, doing tests, creating records. You are eligible for that. Or even pharmacies when they are actually, we have now given, because not many doctors are writing prescriptions in a digital way, but when you go to a pharmacy, they create a bill which is a digital record. It's a kind of a pseudo digital record. So for the limited purpose, right now we are treating that also as a digital record, because what are the medicines which I bought are there as a part of that thing. So, and currently, see, we have this 100 records thing. In a month, if you do 100 records, only then you become eligible. If you have any feedback on that, you can give it to Vikalp and he will pass it on to us. But the policy is right now that you have to do 100 records, and then on the 101st, you get the digital incentive under the scheme. And when we thought initially it was a good number, I mean, a doctor invariably sees more patients than that, but
yes. Thank you, sir. I think one last question, Dr. Adil Ahmed has asked. Sir, you would want me to read it, or you can unmute yourself and hello, Dr. Adil?
Yeah, my question was actually, some companies while buying insurance, they just hire a doctor and they don't explain the terms and conditions. We just have to agree to them if we want to buy insurance. It feels like it is a kind of hazard because everyone, almost everyone doesn't read terms and conditions. They just accept it, right? I'm just a little bit concerned. What if the insurance companies come to HMS and ask for this kind of data?
I think your voice is breaking a
Maybe
little.
maybe I'll repeat because Sir has also mentioned this on the chat as well. What Dr. Adil's question is that he's little apprehensive that what if the patient gets cheated and insurance company approaches the patient and if the patient agrees and gives the consent, all the documents would get shared with the insurance companies, but might be that the insurance company is not delivering the insurance by looking at the data and so on and so forth. So that's what was the question, if I'm able to comprehend, Dr. Adil.
Yes, sir. I'm saying this because I have my share of experiences with the insurance companies, and I've worked with some of them also. What happens? Doctor calls you after buying an insurance to collect your history, and what happens? They just take 5 to 10 minutes for all the history. Patient either agrees or disagrees. It's kind of trickery. They deceive to get your data and to keep you out of the claims, to get out of the claims. So what if without explaining all the terms and conditions, patient agrees, and or if what if the terms and conditions is 10 pages, so no one will read it, right? And the data, if the patient agrees, the data will automatically be handed over to the insurance companies. Trickery is there. That is my question valid?
Yeah, see, what I see is that one point is sharing of data with the insurance company and their usage on it. See, if a medical history is required to be shared for your claims and any other purpose for getting that insurance, that is a thing I think we'll all have to do. Uh, but the usage of that data by the insurance agency for any other purpose, apart from using it for claims and for settling that claim of the person or giving that policy, that is something which is not allowed. Okay. So if I have to tell someone that, okay, I had a, I had a surgery done for something, that is something, and based on that, the insurance company will decide whether I am prone to surgery or any other thing which is required by them. Then that is a part of their business process, But suppose they take your data, you give them a history, or suppose let's say there is a cancer patient and is being treated, and as a part of the history, they give the cancer patient data is given to them, and the insurance company uses that data to sell it to some other pharmaceutical company. That is something which is wrong.
Yeah.
So, yeah. So the purpose for which the data is collected has to be told. And that is also covered in the act which has recently come out, that you cannot use the data for any other purpose for which you have collected it, unless it is properly stated. So that is something, even as a part of our EBDM when it comes on the app. So the doctor, I think maybe you can see that how the records are fetched in Vikalp system. When he is requesting, they have to specify a reason why they are asking for that data, and that reason is also shown to that patient on their application when they are approving it.
Yeah. And just to add to Narendra sir's comments, I see eventually someone has to give the consent, and that has to be the patient. Eventually, patient would only know. So some bit of education over there would be a good thing. And I think when doctors or staff create that ABHA ID, when we also in our PHR app create that ABHA ID, we try to provide some sort of a content that it's important to manage your documents well, your consent well. We see a lot of frauds that are happening on UPI. We see a lot of people try to do some fake phone calls. All of that happens these days quite a lot. These are the side effects of digitization, but eventually there has to be an ownership that has to lie with the individual, because no one would know whether the data is being shared is I mean, the only patient would know if the data is being shared for a specific reason with the right person or not. So yeah, it will be more educational, and I think NHA is doing their bit to educate, but we will do it from our side, and I think doctors can also do it from their side to educate the patient that data is important.
So I hope that clarifies your apprehension around the whole data privacy. If there are no more questions, we'll move to the next session. Again, thank you so much, Narendra sir, for giving all the clarity and taking the time out for engaging in the webinar. Now the next session I'll be taking, which is going to more highlight on how you can make your clinical practice ABDM compliant. So since we have had Vikalp and Narendra sir highlight the use case, usefulness of ABDM in general, how we as doctors can integrate this into our practice is what I'll be lightly touching upon. Let me just share my screen. So there are basically three key points for making your practice DHIS compliant. So being a part of HPR, HFR, and HMIS. So what is HPR? HPR is nothing but the health professional registry. So when you are a healthcare provider, like sir mentioned, in terms of being a doctor or running a lab diagnostic or anything of that sort, you need to first register yourself in the HPR repository. And also you need to register your health facility, be it your clinic or your lab or any health facility that you're running. And these two should be eventually integrated and run on an HMIS or a ABDM compliant HMIS, right? So these are the basic steps, like in the broad sense, how you can adapt to ABDM and like benefit from the DHIS is first get registered in health professional registry. Then you get register your clinic in health facility registry. Start using an ABDM enabled software like Eka EMR. So once you've started using it, then there is a small additional step where you log in and register for DHIS in your HFR profile. So we need to understand the DHIS scheme is always tied to your HFR or the health facility. And once, all the process of linking the documents and those things are ongoing in your clinic, you will get an option to log in and claim your incentive in the HFR profile. So I'll just show some steps around it right now. Before that, there are just basic details that you will need to provide when you're registering. So one would be your medical registration number, your Aadhaar number, mobile number, email address, and clinic details with proof. And when during the time of claim, you will have to provide some account details, a cancel check, and two forms with basic details around mandate form and annexure form. So like I mentioned, as any practicing doctor, you have for you to get registered into HFR and HPR. There is obviously the government website where you can do it. At Eka Care, our EMR is enabling you to do this at a very single step. I'll just show you that demo right now, and just highlighting how we have learned from a lot of feedback on the doctors that are using the EMR, and we have built like the best easy scenario to integrate this into our practice. So I'm a physician as well who treats diabetes patients a lot. So in the end, the EMR should not be a hindrance for our practice, but make it more smoother. So with that intent, we have built some flows on the EMR. Let me just show that. So this is a demo account right now of my colleagues called Dr. Neha. So this is how the EMR looks. And on the left side, what you're seeing is the ABA is red. So the ABA has not been created for this number. So I'll just show you, it's like a 5-minute process on the EMR where I go here and it's asking me for the Aadhaar number. So this is where I need to enter my Aadhaar number as a treating doctor. So once you do that, you'll get an OTP on the registered number 831262. So as you can see, first step was just asking for the Aadhaar number. Now I'm just entering my phone number and 53. So this is setting up my HPR ID. So HPR ID is nothing but Health Professional Registry ID. So that is done. So that's it. Like it's hardly taken 2-3 minutes for me to create my HPR ID on the tool. Then I need to, if we remember that triangle, then I need to create the HFR ID. So this is the clinic name. I give a code, clinic pin code and the clinic address and submit. If you have an existing HFR ID, you can choose that as well. This particular case, I don't have it, and that's it. So I've received HFR ID. So within a span of 4 to 5 minutes, once I have my phone number and Aadhaar ID handy, the registration is done. So immediately all the patients that you see, you'll start seeing it very clearly on the tool itself, like every patient that you must have seen, if there is an ABA or not, and then you can create an ABA for that patient and then so that's it. You can either have your staff create this outside of your routine practice, or you as such can create a ABA ID for the patient only once. Once you do it, every digital consultation that you do with the patient, every record that the patient is sharing with you does get counted as a digital transaction and becomes eligible for the incentive. And there is a small dashboard as well where you get to see. So this is the dashboard that you will see throughout your practice, where we end up showing you the number of patients that you've seen and the number of people who are eligible for incentive and what is your expected income from it. This is a general overview of how Eka can be used to make your practice ABDM compliant. One thing I'd like to clarify, see, using a HMIs, I know we as doctors during our education mostly not always used an EMR throughout our education as well. Maybe there is a steep learning curve is one apprehension I've seen, switching from pen and paper to a digital prescription. In those cases also, I think NHA has come up with a very beautiful solution around it, where they're like creating digital prescription, or you can just even link digital records where you take a photo of that handwritten prescription and link it to that patient's ABA ID. That itself is also considered for the scheme. And or even creating an appointment, like there is a scan and share flow where someone, if you just integrate the appointment system and link it to their ABA ID, that also is considered valid. So overall, just before Imtiaz from our sales team takes over, just want to highlight more how it helps to solve it for ABDM and DHIS better, is there is minimal overhead for the clinician. Because if you're anyway using a digital platform right now for creating digital RX, it's a very smooth flow. There's no additional step. And since there is an app version of Eka as well, you can as well use your staff to do this part of linking and all that aspects. You can train the staff to do that on the mobile app. And like I said, not compulsory to use the EMR to gain the benefit of the scheme. And we have the most optimized solution, like not to brag about the experience, but yeah, it's pretty smooth in that sense. If there are any questions or more, we can take it from here. I think Dr. Adil still is mentioning that to say freely, we get incentivized by sharing patient data with government. What is benefit for patients? So I think, sir, just to add on to this apprehension in a sense, like even Narendra sir said, there is no data which is being shared to the government or anywhere. No one can read the data that is being generated. It's more a log of the patient, and patient is the complete owner without consent. I think that's a very, very integral principle of ABDM if we just go deeper into the policy documents as well. Always the patient is considered to be the owner of their data, irrespective, and without patient saying, okay, I'm ready to share this with you as the PHR app or with you as another doctor, no prescription or valid medical data gets shared across. And incentivizing is, I think, again, overall to up the digital revolution in health. We all know the benefits of digitization, and probably health can catch up on that too very soon. Fine. Okay, I'll then move on to the next. Okay, Dr. Deepak has a question. Yes, sir.
I have some patients with their old prescriptions
Yes.
from 2 months before, 3 months before.
Mm-hmm.
Will it be uploaded to the ABA after registering patient to ABA?
Yes, sir, you can link it. Only thing is a single patients against a single ABA, only you'll get incentivized for only 5 records in a month. So let's say there are 7 prescriptions that the patient has, like obviously to complete the medical history on the digital platform, you will upload, let's say you upload all 7, but maybe you'll get incentivized for only 5. Because,
No, I am not asking for incentives.
okay.
I am asking that will it automatically uploaded by software to ABA previous prescriptions?
Yes, sir. So basically, then what you'll have to do is, as soon as you have created that visit with that patient, just upload the medical records and it gets automatically uploaded, irrespective of the number of records or how old the record is. You'll have to probably click a photo of it and upload it. That's fine. So patient, another question is, so patient can access this data anytime and can share with any doctor he or she visits. Yes, sir. Patient can access it, and patient is in control of both whom or the patient wants to share the record with and for how long. So let's say I'm visiting a doctor just for the coming 2-3 months, and then I am like, I don't want to keep this uh, record of mine visible on their system for more than that. You can even choose that make this available only for X amount of time for this particular doctor. The whole, yes, and the whole idea is that patients don't have to carry their files everywhere. So I would really urge you to try out the PHR side of ACAP as well. The medical records is also built with the same fundamental principles of data privacy and the ABDM principles around it, where you can share this across your doctors. You get to choose which doctors and everything.